Most ADHD treatment plans are destined to fail. Here is the overlooked reason why. We typically frame ADHD in terms of attention, hyperactivity, dopamine, and executive function. However, countless treatment plans fall short, leaving individuals struggling despite correct diagnoses and medications. The reason is not a failure of the model, but a failure to address the foundation upon which all cognitive function is built. That foundation is sleep. Most ADHD treatment plans will fail not because the medications are wrong or the diagnosis is off, but because nobody's addressed sleep. The connection is not a coincidence. It's the norm. 2.6% of people with ADHD report lifetime sleep problems. This is more than double the rate in the general population. Sleep disturbances in ADHD are not just about difficulty falling asleep. They manifest as a wide spectrum of clinically significant disorders, such as restless leg syndrome, RLS, night terrors, sleep apnea, and symptoms mimicking narcolepsy. Yet, sleep is rarely assessed first. ADHD and poor sleep fuel each other in a bi-directional loop. ADHD symptoms, cognitive hyperarousal, and even medication effects directly impair the ability to initiate and maintain restorative sleep. In turn, sleep deprivation directly mimics and exacerbates core ADHD symptoms, creating a cycle of escalating dysfunction. Fixing only one side of this loop is ineffective. The system must be addressed as a whole. The root cause is a state of persistent hyperarousal. The ADHD brain isn't just distracted. It's in a state of chronic, physiological, and cognitive hyperarousal. This isn't a behavioral choice, but a neurobiological state. This is why patients say, "I can't fall asleep because my mind doesn't shut down." This is often driven by an overactive default mode network, DMN. The foundation of this hyperarousal is a dysregulated autonomic nervous system, ANS. In the ADHD brain, the sympathetic nervous system, the accelerator or fight or flight mode, is chronically overactive. Conversely, the parasympathetic nervous system, the brake or rest and digest mode, is chronically underactive. The state of hyperarousal in ADHD is a direct result of this autonomic imbalance. Too much accelerator and not enough brake. Addressing sleep dysfunction in ADHD requires a clinical, systematic approach. We must move through a logical progression. Assess, identify, and intervene. First, assess. Conduct a thorough, targeted sleep evaluation. This includes the sleep history, the 3P model, predisposing, genetics divided by anxiety, precipitating, stress divided by triggers, and perpetuating factors, maladaptive habits. 2. Identify. Pinpoint the specific sleep phenotype or underlying problem. The 4 common phenotypes are delayed sleep phase syndrome, DSPS, the night owl, restless legs, RLS, and PLMD, the unsettled sleeper, sleep disordered breathing, SDB, the interrupted breather, including sleep apnea, stimulant-related insomnia, the medication effect, due to rebound or mistiming of doses. Intervene. Deploy targeted strategies matched to the phenotype. For DSPS, use melatonin 3 to 4 hours before bedtime and light therapy. For RLS, divided by PLMD, check ferritin levels and use iron supplementation, which often improves both sleep and ADHD symptoms. For SDB, refer for a sleep study, polysomnography, and consider tonsillectomy in children. For stimulant-related insomnia, adjust dosing, such as a small evening dose, or switch formulations. Foundational interventions for all types include cognitive behavioral therapy for insomnia, CBTI, and rigorous sleep hygiene. The evidence points to a new understanding of ADHD. It is not just a disorder of focus, it is a disorder of rhythm. Attention, arousal, emotion, and sleep all follow patterns. In ADHD, when one of these rhythms is off, they are all off. Sleep is the most foundational rhythm. Managing ADHD without addressing sleep is like building a house on a shaky foundation. The path to improved focus, emotional regulation, and energy in ADHD begins with restoring the fundamental rhythm of sleep. By systematically assessing, identifying, and intervening in sleep issues, we directly treat the state of hyperarousal that undermines treatment. Better sleep, better rhythm, better outcomes.